Make that a safe assumption. Or at least you're here, ready to go. Alright, so I'm just trying to gauge how I'm going to do the next test. So next, on Monday then we have holiday, right?
Yep.
So then Wednesday is the next lecture, is it?
Yes.
Okay, so we're on track. So the week after that, the Monday is the next exam. With that exam, do you have something right after this?
No.
What do you have on Mondays? What do you have after our lecture? I guess
We have chemo lab.
Echo has lab. I guess we can't do that. Okay.
But Fridays.
I'm just trying to think how I want to do the next exam because part of it is video clip, and usually I just do the video clips in here. Yeah, I'm not doing Fridays.
No.
Okay, let me look at some options because there's a few video clips on that next exam, so you need to be able to see clips. Usually I do it in here, but there's at least one person that can't do it in here, so I gotta figure something out. Alright. So, get ready for video clips. So, we're talking about stress echo, so what do you think video clips like we might be looking at?
Probably the heart.
Wall motion. Wall motion, definitely. So, I'm just gonna touch base. We're not gonna have a lot of time today, but let's just go over the important take-homes from stress echo. So, tell me about stress echo. What's the first thing you think of?
4 views.
4 views. Okay, so what about the 4 views?
Plaques.
Okay, next one.
Short axis of the mid.
Yes, good. And
Apical 4.
and
Apical 2.
good. So those are the 4 views in stress echo. What do you want to know about them? What do you think is the most important thing to know about the walls?
If they're moving.
If they're moving is absolutely correct. What else do we need to know about the walls? So you're going to look at the contractility. So as far as that stuff goes, you're looking at scoring them then, right? So what are the scoring levels? 1 is?
Normal.
1 is normal, 2 is? Hypo, good, 3? Akinetic, and 4? Dyskinetic, 5? I spelled that right. Okay. So good, you need to be able to score the different segments, and what else is relevant on the walls? What else do we want to know about the walls? So we'll score what their characteristics are. The degree of systolic wall thickening, okay. Oh, yes, segments. So know your segments, okay? When we know the segments, what else are we going to be thinking about? So tell me what are we looking for in a stress echo? What's the goal of doing this?
Whether there's changes post-exercise.
Okay, what changes specifically? Ischemic changes. So when we talk about ischemic changes, what do we want to know? This is why we learn the wall segments.
Focal.
We want to know what coronary artery supply we're talking about. So you need to correlate what coronary artery is associated with each of those segments. Okay? So very plausibly I can ask and will ask most definitely, I will give you a wall segment or a couple of wall segments and ask you which coronary artery is likely involved. Okay? That is the essence of what we're doing in stress echo. So in addition to showing some stuff going on here. So in conjunction with an echocardiogram during a stress test, what else are we doing?
EKG.
We are definitely doing an EKG. So the EKG stress test is going on at the same time we do the stress echo. So typically we will take a we'll take a resting set of echo images first, and as we've shown on the, I did kind of a display at the end of that Panopto from the ASE stuff because I couldn't find my disc from Feigenbaum, but it was just showing different wall segments. So on a standard stress echo representation, you're going to have kind of your, we do a 4-image split on your screen. So some of your ultrasound systems you'll notice have like a 4x4 layout. What we're looking at is we typically will do the rest images. You'll take a clip of those, all 4 of them at the same time on rest, and then after the stress, it will pair them side by side with their representative post-stress images. So these are the rest. So the way they're always displayed is resting is on the left side and post-stress on the right side. So again, in a resting set of images, if I'm taking this on an ultrasound system, I take my set of 4 first, and I will actually take a clip of them, all 4 running at the same time on the screen. And in that case, I have peristernal long axis here, short axis here, 4 there, and 2 here in rest. Post-stress, it splits them out, so I have long axis at rest and long axis post. I'll have my short axis at rest, short axis post. And then the next frame is going to be another set of 4 images with 4-chamber rest and post and 2-chamber rest and post. Okay, so the resting is always on the left side. When we do a dobutamine stress echo or pharmacological one, or a like an inclined bicycle one where I'm going to do resting, I'm going to do a peak, so the maximum workout, and then we do a post-recovery images as well to see this has gone back to normal. So in that case, we'll do 3. But pharmacologically, we can do up to 7 of those on a stress package of a system. So just be familiar with how they're kind of laid out. So always be looking, if you've got 2 peristernal long axis views, you're seeing a progression of what's happening throughout the cycle. In dobutamine or pharmacological, we do a set of 4. So we're going to do a rest. We do a first dose, a peak dose, and then a recovery dose, or recovery after the doses are complete, watching the patient come back down to normal. So that, or they could do up to 7 of those. So just look at your progression of images. That's kind of what we're looking at. We're just looking to see, how does it change from one frame or one part of the exam to the next part. So what are normal changes that we're looking for in a stress echo? What do you expect the heart to do when it's exercised?
Increase the heart rate.
Okay, increase heart rate.
Decrease
Increase contractility.
Okay, so the decreased in systolic volume for sure, so it's going to be squeezing harder. My ejection fraction goes up typically, so a bigger amount of blood's getting ejected out of the heart. I did mention in my slides that you are going to see a mild increase in volume in diastole because of the calf veins and the sinuses pushing that extra blood volume up into the heart, but that's very, very minor. But if we're seeing a significant dilation of the images both in diastole and systole, that's a sign that something bad is going on. We're getting a bigger backup of blood. It's not being ejected like it should. So physiologically, it's normally get a slight amount of increase, but if you're getting a decent amount of increase, that's not a good sign. Okay? That usually means that something's not as efficient, and so then we're looking for a wall segment that's causing that. So thinking back to EKG when we talked about stress exams, what physiological things do you expect to see the patient experience during stress, in a normal situation? So faster heart rate, bigger contractility, all that stuff that we talked about on the heart, but what about just physiologically on the patient?
Respirations.
Yep, so yeah, they're going to be breathing faster, they're going to be sweating. So all those are normal things. They should not be nauseated, they should not be, feeling vomit, like they got to vomit. They should not have syncope. What's syncope?
Dizziness.
Okay, so the passing out or feeling faint, okay, that's not normal. What do you expect on blood pressure response? Okay, so it should be increasing. if we ever get a really big decrease, especially if it's a big decrease in blood pressure, that's a bad sign for sure. But the patient's also going to be likely pretty symptomatic. Okay? So just kind of think about what the normal heart reaction to exercise would be. If I do a stress and I don't see the heart change and it's just doing the same thing, would you think that's normal or abnormal? That's abnormal because we're pushing it harder. We should expect it to start squeezing harder and faster. So if we're getting a very similar look to what resting was, then we're not doing it right. Now, the one caveat is when we take it. So if we're doing a treadmill stress test, for example, and we stop the treadmill, we get them over to the bed, we struggle getting our images. If you take more than that 90 seconds, it can return to normal. Okay, so if I've gone too long, it could be back to normal because I missed my window of opportunity. Okay, so just like looking past a really stenotic carotid artery, so if I've got that carotid artery, I've got a big stenosis in it, if I'm more than 2 centimeters beyond that, my velocities can be back to normal, and we missed the disease. So in stress echo, same thing. If my time window has gone by too far, your exam is useless.
Can beta blockers kind of inhibit
Absolutely.
some of that, making things look, maybe not change as much as they should?
Right. So, and that's a good question, and I think we mentioned this in EKG as well. So when we have a stress exam, we actually, a lot of times will hold beta blockers and stuff. What does a beta blocker do? What does it do physiologically on the heart? So it reduces the heart rate, right? It doesn't allow the heart rate to get up. So the point of doing a stress echo is that we push it so that the heart rate increases. And if we're fighting against a medication that's counteracting that action, we're not going to get a good test result. So usually 2 to 3 days before the exam, the doctor will have them hold their medications so that they don't do that. But if the patient absolutely has to be on it, we just have to modify our expectations of what's going to happen. We may not be able to get them past the target heart rate. Okay? What is the target heart rate? How do we calculate that again? 220 minus the age. Good. So, so you take their age, you subtract that out. That's our 100%. To have a valid stress echo done, what do you have to have?
80%.
You have to have at least 80%. Yeah, 80%. 80%. For some reason, I'm 85 in my mind right now, but 80% at a minimum. Okay, if you don't get that, it's an invalid test. Okay. Once we hit that, are we good to go? And just, we hit 80, we're cut it off and be done? No, your better test is always getting close to 100 as possible. If we don't get close to 100 or don't hit the 100% target heart rate, that's okay. Number one, we're looking for symptoms. We're also looking for patients' ability to tolerate the exam. So if they can't push any farther and we feel like they're not going to be able to do that, they're not going to push themselves harder outside of the clinic, then that's okay to stop the exam. The question is, people will get just bored and they'll be like, yeah, I'm done with this test, and then they go out and they do some marathon or something and drop dead. Okay? That's problematic. So you do want to push the exam as hard as you can. You might have to encourage the patient to go further. In the end, you can't make a patient do what they're not willing to do, right? But we will try to teach them how important that is to get a good exam. Most of my patients would quit early, for sure. Sometimes when you push them just beyond that threshold, then the disease didn't come out of nowhere, but the reaction to it did. So if you push them just a little bit harder, you're going to find that. Then at least you can treat it. They can stent, they can do bypass surgeries and stuff if they need to, but it's important to push that. So having said that, so I mentioned the treadmill. So what types of exercise, what types of stress tests do we have?
Exercise and medication.
Yep, so it's either pharmacological or exercise. So medicated, pharmacological. There's a few different agents, the most common being dobutamine. Okay, that's the most common by far. So with that, and compared to the stress exercise, what's the difference between them? Why would we want to do an exercise stress test rather than a pharmacological stress test or vice versa?
Exercise more common?
It is more common.
It's dangerous anytime you're giving people medications. You
Yep,
don't know
anytime
how
you're
to
putting something into a patient, that's less optimal from a physiological standpoint. It's an increase in risk or liability issues if you're injecting something into somebody. But why would we do a medicated one versus a,
Someone's
There's
not-
a little lady that can't walk.
yeah, I mean, so if they can't walk, if they can't tolerate it, they've got maybe one limb, stuff like that's obviously going to be difficult to do a stress exam with. So we've got to work with the patient. It might be an elderly patient that's frail, different things like that going on where we would want to medicate. It could also be somebody who's got a lower cognitive ability, we'll say. Somebody who's maybe a little bit mentally disabled, might have difficulty being on a treadmill and working around that stress of the situation. Those different scenarios might be better to have a medicated type of an exam.
So they still have the same, like, symptoms, like sweating and
Yeah.
the whole thing? Huh?
Yes, so the symptomatic stuff would be similar. The difference is with the, and it's very, very weird, when you have the opportunity, and most of my students have the opportunity to see stress exams, some of them have the opportunity to scan them. So it's pretty fun. You want to be, if you're getting involved with scanning, you really want to know your wall segments. Okay, that's really, really important. But you're going to have patients that feel very awkward when they're laying on their bed. They're not used to exercising. These, somebody who's 85 years old, maybe a little bit frail, has a hip broken or something like that. They'll be laying on their side and their heart just starts racing. So it feels very weird to them to have that reaction, and they feel very uncomfortable because they're not used to that. They're not used to pushing themselves to that degree. So there's just a bit of a workflow. So as an echo tech, you're going to have to be a little bit compassionate with your patient and be able to work with them and help them understand that that's the normal thing. Then obviously we're looking for things that are not normal. So if they start getting nauseated, breaking out in a cold sweat and stuff, just profusely sweating, they get pale and gray. I mean, those are all bad signs. Their blood pressure might drop. You're looking for stuff like that. So whether they're exercising or getting a dobutamine, it's going to be we're looking for similar heart symptoms. Okay? They might get angina. They might get some ST segment changes on the EKG.
Question about dobutamine in a pacemaker.
Yes.
Would it be, I mean, understanding that everyone wants the best for the patient, is it, when we have the patient, even if the patient came with a nurse from, say, the ER or wherever, is it our responsibility as technologists to look at the chart and know that they have a pacemaker before dobutamine is administered?
Dobutamine shouldn't interfere significantly with a pacemaker. What is the job of a pacemaker?
To pace the heart.
To pace it, how? Is it supposed
If
to
it-
control it all the time? Is
No,
it
it
supposed
just
to...
detects if it misses something and then it kicks in.
Right, so it's preventing an extremely slow heart rate, so it shouldn't kick in if we're giving dobutamine. We're just increasing heart rate. Now, if it's a defibrillator, that could potentially be problematic, but I guess it would depend on the rate. And typically, if somebody is in a stress test and they have a pacemaker, it's under the control of a cardiologist, and they will make those decisions if it's adequate or not. If it starts, it's going to be triggered to know certain, if it's extreme heart rates, it's going to kick in. But if you're in your normal exercise tolerance range, it's unlikely that those pacemakers are going to be set to defibrillate at that point. You'd hate to be exercising, I was like, ka-chink. That would not be good. So likely those pacemakers are going to be beyond the range of what we're looking at. Okay? But good question. So, and those are the types of decisions that will be made by the doctor. Okay? And if you, has anybody seen people that have had pacemakers implanted?
Yeah.
Okay? So they've got this thing right on, it's like a box that's right underneath the skin. So it's like you get the skin line, you get this big bulge that comes out in a very abnormal looking, it's not a natural thing. So it's fairly obvious that they got one. It's almost always on the left side. It could be on the right side, but it'll be pretty obvious when you're setting up for the exam that they've got it, and they'll probably tell you anyway. And looking in the chart, I was always a big fan of looking in the chart to find information that's relevant to my exam. Having said that, nowadays with the electronic medical records, the way they're set up, is if you go into it, you're signed into the computer under your sign-on and password. you get flagged on every page that you look at. Whether that's good or bad, if it's relevant to your exam, it's fine. But if you're looking at pages in the chart that are not relevant to your exam, you could get flagged for a HIPAA violation. Okay? It's just the reality of what we live in now. Having said that, I really liked it back in the day where I could look through the chart entirely, because I would find things in sections that were not necessarily relevant that I found useful information for my exam and why the patient's having the symptoms and stuff that they have going on. Or you may come across a procedure that they had that may affect the exam that I'm going to do that maybe somebody didn't think was relevant to my exam. So I am a big fan of looking through the chart. Just know that nowadays you're going to kind of, you got to be cautious of what pages you go on, because your name is tied to that from the moment you open it. Okay? Any questions along that line? Yep.
Could you see if you asked the doctor, like, see more of the...
Could you ask them if you could see more into the chart?
Yeah.
I think it's relevant. I mean, if you think that there's something that might be relevant to your exam, I don't think there's harm in looking at it. Just know that if I'm looking at somebody's chart like that, in the back of your mind, think, okay, is it reasonable for me to look into this? And if somebody was to adjudicate this and look at it, because each hospital now has a compliance officer who's like the HIPAA police. And they can make judgment calls. They can say, okay, yeah, it's okay that they looked into that section. Okay, but just keep in the back of your mind, if it feels like it's wrong, don't do it. Okay?
Patient records too, they're not blocked. It's not like you need like a special password to get on.
Yeah, they're not blocked. It's not a special password, other than when you're logged into that computer. And say it's the Epic system at most of the hospitals in the Northwest. You're logged into that, and you log in, and your name just comes up. If they went and did an audit, they would see your name tied to each page that you went into and what time you went in and all that kind of stuff. Just keep in the back of your mind, if it feels wrong, just don't do it. Okay? But if it's relevant and you think you need to look at it, and you're scared to look at it, yeah, ask your supervisor, ask the doctor if it's okay. They'll back you up. They'll tell you what's relevant.
Or better yet, ask the nurse to pull it out.
Or have them do it under their assignment. That's even better, yeah.
But the doctor will just tell you.
Yeah.
They'll just offer you that information.
It is so nice to scan when a doctor gives you the relevant information. I used to scan in Colorado Springs for one of our accounts was a vascular surgeon. We had 2 different vascular surgery accounts, and one doc would never tell you anything. They'd never give you a diagram of what they did, what procedures they did, and they just had this person with symptoms, and your job was to go figure it out. Then you get in scanning, and you find out all these different shunts and stuff that they did, and different procedures, and it was a stinking nightmare, and your job as a tech is to kind of map out everything that's going on. People hated working for that doctor because they always had to do so much extra work when they could have just provided them a map of what they did. Another surgeon that I had did the most beautiful surgeries you can imagine. I mean, it almost looked natural the way that he did his surgeries, and he gave you a mapped out diagram of what stuff was done, so that when we went into it, it's like, oh, I know I need to do this, this, and this. It didn't complicate my exam, it just made it so much easier and quicker to get through what I needed to do. So anytime you have more information, in my opinion, the better. Okay? What's bad, and as a tech, and where you get nailed on lack of critical thinking, is when they give you that information and you never looked at it, and then you just sort of fumbled your way through the exam, and then it's like, well, what about this that they showed in the exam last time? You didn't even look at that, and that just makes you look really dumb really fast. So my advice is always look at the information that's available to you. It's going to make your exam easier. 5 minutes of preparation could narrow your exam time significantly. Okay? So wall segments are going to be important. Being able to grade them is going to be important. Knowing the types of stress tests, we talked about exercise versus pharmacological. So dobutamine is the most common pharmacological. What types of exercise stress echo do we have available? So we have a bicycle. So the original was done on an upright bike, okay, a stationary bike, and they have them on there. Then they still have to put them on the bed and scan afterwards like we do on our treadmill. Treadmill is pretty straightforward. It goes, according to the Bruce protocol, it goes higher and faster every 3 minutes. We're going for what's called the METs, or the metabolic equivalence. It's their way of putting a quantification on how far they've pushed. Okay? There's modified Bruce protocols and stuff like we talked about in EKG. So the treadmill you do and the upright bicycle you do beforehand. You'll just set a resting images first, then they get on the treadmill, they're all hooked up to the cables and wires. The nurse or the doctor or somebody's monitoring the EKG the entire time. They stop that when they've hit when they either see symptoms come up, or they see EKG abnormalities, or if the patient can't tolerate it, or we've just completed the whole cycle of stuff and we're good. Or they've hit their target heart rates and we're comfortable with it, then we end the exam. From that point, they get off the bike, off the treadmill, get over to your bed, lay on their left side, you make sure that you're all hooked up to the EKGs again. Because all of our clips again are triggered off of the EKG, and if you don't have a good EKG, you're not going to get good clips. They get on the bed, you take your post-stress images. It's really, really important that we get all of our images from 60 to 90 seconds from the time the treadmill stops. So if my patient's usually back here on the bed with the nurse or doctor, they're doing their thing. As soon as that stops, I start my recording on my system. Okay? Even though the patient's not on the bed, I'm not taking pictures yet. Because there's a timed amount of time that you have, and that's going to be on all of your images to show how far out you scanned it. So physiologically, on a normal response, I know that for our stress exam that we're going to do for lab, we've got 2 minutes to do it. It's at rest. Some people think that it's easier if we have the opportunity to kind of scan ahead of time and find out where the windows are. And generally speaking, you're going to have your windows similar, but honestly, they change after stress. Where is the heart anchored in the body? Where is it actually attached to something? Pulmonary veins, the back of the left atria. That's where it's anchored, and then the SVC and IVC. So that area up top here is where it's anchored. Everything else is movable. Okay? So what happens when you're breathing fast and heavy? Okay? The heart's moving, and it's not moving straight up and down or side to side. It's swinging like this because it's pivoting off this point. Okay? So my stress echo windows change after stress. And getting your patient to hold their breath during rest, how's that experience?
Not great.
It's not fun at rest, right? It makes it so much more fun after stress. So keep in mind that your patient's breathing quickly. They're not going to be able to hold their breath like they were before because they need another breath right away. So they're breathing faster, heavier, so things are just moving. So honestly, your windows are not the same windows as when you start the rest. That's really not an advantage to be able to have. But we do get a rough gauge. What is nice about doing rest versus stress is that you'll set up your depth and everything the way it is. And on the stress echo package of your system, it should kind of lock that in. So when you come back to that view, it makes those changes for you and puts it back to what was optimal for that window. Okay, which is nice. So all the systems you're going to have a stress image. While I go and have you take certain clips as you're doing your rest images, when you do these on the stress test, what you do is you trigger the system, and then when you move to the next, it will take all those clips. Then it jumps to the next view, you get your windows real quick, then you jump to the next view, and so forth throughout the exam. After the exam, you're going to go and take all the clips within the parasternal long axis, and you're going to find the one that's the best, and you're going to select that one. Then you go to the parasternal short axis, do the same, etc. That way you're going to represent all the best images you can get. So it's going to take multiple clips throughout. It's not like you only have one shot at each view, okay? Which is nice. Some systems I can jump back and forth on. Other systems, once you change views, that's all you can do for that view. Okay, so treadmill, the upright bicycle, stationary bicycle, and then what's the other bicycle? Okay, it's a recumbent bicycle. It's laying down. It's like a 30-degree tilt on there. What's the advantage of that over the treadmill or the stationary bike, just upright bike?
They're already laying on the table.
Yes, so they're laying on our table and we're scanning them as we're going. So the advantage of that, and it's always a bigger advantage to have that, instead of having my 60 to 90 second window, I can image it at peak when it's the absolute maximum, so we know we're getting the best test. So honestly, an incline bicycle probably is your best option for a test. Okay? We're not having to give the patient medications, which is a potential risk, and we're able to image at peak. The advantage of dobutamine is that if they can't tolerate these exams just because of structural issues with their body, we can also image that at peak. The downfall to that is they've got a medication inside them, and so we have to monitor that, and we have to wait till it comes back down to normal before we let them go, because it is a risk once you involve a medication. Having said that, we also use contrast agents to be able to enhance our echo wall detection. So we'll use echo enhancing agents is what they prefer us to call them now, but contrast can be used as well. The reason we don't like to say contrast is because what do you think of when you think of contrast? We think of angiograms, we think of things that wreck kidneys, and patients think the same thing. So some of them may have had bad experience with that, and they may have reacted to it. That can cause some kidney damage. So when we say contrast, they get pretty apprehensive, when in reality it actually doesn't have the same effect at all. Okay? We're using a lipid-based and an inert gas, so things that don't affect the body in a negative way. So the contrast agents that we use are not the same as like a CAT scan, CT type of contrast. Okay? Okay, so know the different types of stress echoes, know kind of the advantages and disadvantages of each. Okay? Know the wall segments, know the coronary artery supply to each of the walls, how to score it, the layout of it. Beyond that, so I brought up contrast agents. So what does the contrast agent do? So we talked about, when we talked about right ventricle and interatrial septum and that kind of thing and looking for shunts, what type of contrast were we using for that? So it's agitated saline. So these are bigger, they're bigger small bubbles. Okay? They're small bubbles. We don't want big air emboli going into veins and stuff like that. But we take those, the two syringes with a stopcock on it, and it's got a little catheter type thing that goes into the blood, and we go back and forth with it to agitate it. Then we inject it. That only goes through the right heart. Why does it only go through the right heart? Because they get popped in the lungs. Okay? And it doesn't affect the lungs in any major way. Now, if I let a big bubble accumulate in there, then it could be bad. Or if I've got very slow flow in the veins, that could cause air to congregate together. And what happens when bubbles congregate together?
They get bigger.
They get bigger again. So we do have to be careful of that, make sure that the physiological state of the patient is able to handle that. And so that's the agitated saline. These contrast bubbles are much, much smaller. Do you guys know roughly what the size of a human capillary is? It's in microns, yeah. So it's like 5 to 7 microns in diameter and size. What's the size of a human red blood cell? This is on the test. So roughly speaking, it's about 7 microns, give or take a little bit. So the idea is the capillaries, when the red blood cell goes through it, it's supposed to squeeze through that area. Part of that pressure and change is what causes the gases to exchange properly. The blood, the fluid component of it actually goes out and seeps into the walls and the tissue, and then it's supposed to come back in and be drawn in by the osmosis and different things like that. That's how the blood kind of works. So these bubbles actually pass through it. So these are less than 5 microns in size. So they pass right through your capillary supply, so it easily goes through the left and right side of the heart. We're going to have to decrease our power outputs and stuff of the system, so it's actually a very dark image, because when the bubbles come up and light it up, these are very intense reflections that we're getting off the ultrasound beam. So it will light up so well. Now, if I've got a strongly shadowing rib or something going across my image, that shadow is still going to be there. So it's not perfect, but it's, it can often enhance little areas where you just can't quite see the definition. If you watched my video the other day on the Panopto, even the stuff that's from the ASE, some of those images, at least the way that we're looking at it on our monitor, it was not good enough to see the internal wall of that. So many of those images I would have actually used contrast. Okay? Even though I am a big believer in being able to get the best window, and I think that I can most of the time see it pretty good. If you're feeling kind of the gut reaction like, I can't quite see it that well, just use the contrast. Your life is going to be so much easier, because then you'll end up having to do it anyway, and then you're going to be like, why did I struggle for so long? Okay? So if you can't see it clearly, you can't get a good window quickly, use the echo enhancing agents. Okay? So Again, if I see 2 wall segments or more, well, a minimum of 2 wall segments, if I can't see them, I need to use contrast. That's the rule. So you want to be able to define all these walls very well. You're going to do, on the resting echo, you're going to do the contrast first. It only lasts for a few minutes in the body and then it dissipates. So you'll actually need another injection of it before the stress test is over. So when your patient is getting to the end of the exam, you kind of gauge how they're doing. You have to monitor how close you think they are to getting ready to go, because before we get them off the treadmill and over to the bed, we have to do another injection. Okay? So you want to make sure that that's set up properly. In dobutamine, we can actually do infusion pumps that will help keep a constant dose. Okay? But it's important to keep that because these bubbles will dissipate very quickly if we're not careful. Okay? The last thing you want to do is inject a big bolus of it, and then you got sort of a degraded image because you got some contrast, some not. You need to make sure it's good. So there's definitely technique to doing that correctly. Okay. Trying to think, anything else that comes to mind on stress echoes? Oh, perfusion is what I want to talk about. What is perfusion?
Blood flow.
Okay. So it's the essence of the tissue getting the blood supply it needs, right? So inside the muscle, we're looking at perfusion. So when we talk about a lack of perfusion, we're talking about a stenosis or something that's causing a blockage to that. When we use these microbubbles, because they go through capillaries and stuff like that, just before it goes in, well, it'll go into the chamber, but it can also go into the walls. So if we're looking at like a liver, for example, we put contrast in it, you'll see actually all the little capillary beds will light up. There's actually a trigger on most ultrasound systems now that you press the trigger and it bursts all the bubbles, and what it does is it puts a very high power output for a few moments, and it destroys all the bubbles, and then it resets itself, and then you'll see it fill up, and it starts a timer to see how long it takes to fill that up. If we're talking about a liver, for example, and it is now FDA approved for liver use in the US, they've been doing this in Europe for a long time. What they'll do is a cancer, what do you know about the blood supply of a cancer? Is it the same or different than the blood supply, or the demand on blood supply, I guess, as compared to regular tissue? They're pretty vigorous, so it fills it up really quick. So if I'm looking at a liver, that mass lights up first, and then I see the rest of the tissue. So you can actually see the definition of the mass by the blood supply of it. That's where they use contrast in looking for masses. In the heart, we're looking for blood supply to go through the muscle, and if I've got a stenosis, what would you expect to see with the contrast? If we're not getting blood supply to a certain segment, it's not going to fill in, right? So you're watching through the wall, you're watching where the little filling comes, and then you're going to see an absence of fill. So it's going to be a dark area around that's not showing fill. So if we're doing perfusion echocardiography, you're going to see an absence of filling in that area, at least for a little bit. Okay, it might eventually get there if you wait too long. Okay, the modality that's best at looking at perfusion imaging and looking at blood supply getting to tissue is nuclear medicine. Okay, so they have radioisotopes that are kind of tagged specific to the tissue type, and we're looking at blood supply getting into that. So nuclear medicine is better at perfusion than we are. But we do have the ability to look at it with contrast agents. Okay? You can't do it without contrast agents. All right, so I just wanted you to be familiar with what perfusion is. That could be important. All right. Anything else on stress echo? I think those are all the biggies. So what it is, the types of echo, how to score walls, how to correlate what coronary artery supplies those walls. That's the essence of what we're looking at. When do you stop a test?
When the patient can't go further.
When the patient can't go further, what else?
Signs and symptoms.
Signs and symptoms.
Target heart rate.
Target heart rate. Good. So those are all things, and some of that could be, so you have your absolute contraindications like we talked about in EKG, like the things that if somebody's got an unstable angina, for example, you're not going to do a stress test on them. The patient I told you about that we had, I think I told you about this in EKG, when I was scanning them and I'd be scanning along and every time they held their breath their heart stopped and I couldn't get a picture. I would have probably stopped, I would have stopped the test, definitely. But the doctor decided to keep pushing and do it anyway, and it turned out to be okay, but a little bit sketchy. HOCM, if somebody's got hypertrophic obstructive cardiomyopathy, that could be a risk, okay? Severe aortic stenosis could be a risk, and nowadays they are starting to do some of this. Okay, so be aware that there's some absolute things that I'm absolutely not going to do it. So if they've had a recent heart attack and the angina is unstable, I'm not going to be doing a stress test. But if they've had a heart attack, they could have had a bypass surgery and they're stabilized and they've gone through procedures, and maybe we're doing it just to see how well it's tolerating it. Okay, we could be doing it on somebody who has permanent wall damage already from a prior heart attack. That's okay as long as it's stable. Okay, so those are kind of relative type things.
So if someone has had a heart attack and they have akinetic walls, do you exclude that from your calculation so it doesn't? Nope,
still part of it, because it still affects the hemodynamics. Okay, so the question is, if there is permanent damage that's done, I've got scarring, do I exclude that information? That's definitely included because it's affecting the overall dynamics of cardiac output.
Okay.
So, yep, we definitely do it. But we expect it. So we're not surprised to see that their EF is at 45 instead of 65.
So you just compare it to their last known ejection point?
Yes. Ejection fractions and wall scoring too, to see. So what we do want to know is if we'll say that this wall here was all akinetic, you know, and that's stable. It's if somebody's had permanent scarring, it's going to show up as very thin wall, less than 6 millimeters, and it's going to be bright, and it's not going to be thickening. That's a scarred akinetic wall. What we don't want to see is that that area is now expanding and it's growing. Okay, we don't want to see that. We want to see that when we've reperfused it, we're not going to be able to revive dead tissue, but we want to see that the surrounding areas are now contracting the way they should. And often what you're going to get is a compensatory contraction on the other side. So this wall's out and having issues, this wall's typically going to squeeze harder and stronger to compensate for that area. So we're looking to see that that disease doesn't spread if we're looking at somebody who's had a prior heart attack. The other thing that we are more commonly doing nowadays is diastolic type of stuff. So what do we know about diastole? What types of things are we looking at for diastolic evaluation? Do we look at thickening of walls?
Filling of the chambers
Okay, and how do we determine filling of the chambers?
by the area, and as well as outflow and.
Yep, so Doppler. So we're looking at hemodynamics. So nowadays we are actually starting to do a lot of post-exercise Dopplers. Okay, often we still go for wall segments first because if we're out of that 60-second window, we're going to see some, we're going to miss it. Okay, so we do the walls first, and then we'll often do some Dopplers after the fact. So if I'm looking to see how stenotic an aortic valve is and if it's relative to cardiac output, so say for example somebody's got a very low cardiac output and they've got a valve that's kind of borderline severe, moderate to severe, and I'm trying to determine where that is, I might do the stress test to put more load on the heart to see if the velocities increase, or if they had a low cardiac output, maybe there just wasn't enough blood to really push it. Okay, so sometimes the leaflets don't open because it's not being pushed very much. So when we do the stress test, they actually start opening more than they were before. Okay, so we want to know if it's the valve itself is stenosis or if it's just low cardiac output that's just not opening it enough. Okay, so we'll do exams for that type of purpose. We could do it for HOCM. It is risky, and patients that have high-grade aortic stenosis or HOCM, it could be dangerous. So if these patients do go down, they go down hard and you might not get them to recover. Okay, so it is more dangerous. Okay. Otherwise, we're looking for physiological changes in diastole as we do the stress test. So we'll do that post-stress. And you could, in the future, you could actually implement these in different ways. When I was in Colorado Springs, we actually did a patient that had a lot of symptoms, and she was scanned in the general lab. She had a lot of work done, and we ended up doing a stress abdominal exam on her. And we actually did find some stuff that was not found at some very large teaching hospitals in the country. because we did a stress test on something. So honestly, when you get something that's abnormal with a patient and you can't, by testing, find what's going on, you can sometimes go beyond the mark and kind of, you try to elicit the situation the patient was experiencing when they had those symptoms. So if I'm looking at a hernia, for example, and I'm laying them flat on a bed and I'm getting them to do Valsalva and all that kind of stuff, nothing happens. But they swear that when they were shoveling the sidewalk that I had this big bulge come out and then it went away and it was painful and all that kind of stuff. You might get them to squat or do something that was similar to the action they did when that happened originally. Because sometimes in a medical situation we're not re-simulating what they did when it happened. So sometimes putting a patient under stress for no matter what it is could be a valid thing to be able to prove what disease is happening, what disease processes. So Doppler can be done after the fact. So you can look through the textbook at the various types, but it's going to be basically diastolic stuff, so it's mitral inflow. You're probably not going to need Valsalva, but you could. Tissue Dopplers, you could do pulmonary veins, stuff like that. And I think that was the essence of that chapter. Any other questions on stress echo? All right, sorry the slides were boring. There's just, most of stress echo doesn't show well on a still picture. That's why I didn't have a lot of stuff to show on there, because really, when it comes to wall stuff, and like I say, for this next exam, I will have video clips, and those video clips guarantee you are going to be wall segments. So look at the actual hearts beating, be able to identify what walls they are, and be able to associate what coronary arteries supply those walls.
So should we try to find like YouTube videos going to stress echo?
Yeah, you could do YouTube videos. You could use Feigenbaum's disc has some of those clips. Other online content. Just the more of the stress echo images you can look at, the better. I did the ASE one, so you can review the end of the Panopto that I did for the lecture, and I go over a few of those, so that will get you an idea. But the more of that you can see, the better. All right. Be safe in the snow.